Today in Health IT, we have another interview from the CHIME Fall Forum. And what we did was a set of interviews in action, which we are really excited about. And I'm looking forward to sharing with you. My name is Bill Russell. I'm a former CIO for a 16 hospital system and creator of This Week in Health IT, a channel dedicated to keeping health IT staff current and engaged. Again, as I said, got a great opportunity to go to San Diego, visit with some CIOs and the people that make the magic happen in healthcare and healthcare IT. And here's another one of these great interviews. All right, here we are from the CHIME floor with Dr. Sean Kelly with Well Health. Congratulations. Where, Doctor, so where do you practice?
I'm at Beth Israel Deaconess in Boston, Massachusetts, Bill.
Up in Boston, just came back from Boston. Were you at the health conference?
Yes, I was.
How was it?
It was good. It was really good for connections in industry, strategic partnerships, direction of the industry. It's less about meeting with provider side people at that conference was my
It was really well put on though, don't you think?
Yeah.
I mean, they do a great job with the conference, and I love the artwork too.
And it was, I think it was fun. I mean, to me, seeing the innovation is really interesting, and some of the mix of the big companies and the little companies and everything in between, and how that can be, strategically cobbled together or stitched together is an interesting.
Yeah, some of the conversation. I was talking to a startup, and there's two people there. I'm like, so tell me about your company. It's like, it's us two and the three other people back in a coffee shop.
Right, here's my garage.
And they were showcasing their product, and I'm like, well, what are you here for? It's like, get funded.
Yeah.
Essentially, we've got a product, we're showing it. We've got some clients. They actually had some clients. I was like, that's an impressive start. I'm sure they're going to get some traction there. So recently with Well Health.
Yeah, I just joined Well Health as the Chief Medical Officer, and as a practicing emergency physician, really enjoy trying to bridge the gap between the real world with consumer grade technology and the world of healthcare that we've all grown up in, and trying to usher that in ways that make sense for all of us.
All right, so you're going to educate me on Well Health, because I just had Michelle Stansbury on the show, Houston Methodist, and she talked about Well Health, and she was excited about the results that they were able to get. So give us an idea of what Well Health does.
Last mile of communications to patients. It catches any signal you want to send them, whether it's coming from your EHR, RegSchedule, numerous other third-party vendors that do billing, forms management, manual messaging. Pretty much anything where you're trying to communicate with a patient in the ecosystem, Well Health can grab all that, pull it together, and send it to you as a patient in a form that you want. It can be voice, email, but the large predominance is, guess what? A text to your phone or your other platform.
Well, that's the thing she was saying. She said, the portal's nice, and we get this much activity on the portal, but we found that texting is a better form to interact, because people are used to doing that on an ongoing basis.
Yeah, the trick is you have to go to where the patient wants to be, and sending them to a separate place, whether it's an app, a portal, a third-party thing, your own hospital website, can be problematic because there could be authentication, there's friction, there's user issues, and then coordinating a use case where, gosh forbid, you have to do 3 different things at 3 different places. If that can all be put together into a text with AI and chatbots automated, and it all just works, and you can complete those transactions, confirm an appointment, schedule an appointment, or more valuable, clinically relevant use cases around pharmacy, around meds, around post-discharge, pre-discharge. Just think of the multitudinous use cases out there.
What about med adherence? Is there anything you're doing in that?
Yep. The amazing thing is, Bill, the atomic elements are all there. And the funny thing from my perspective, is many hospitals actually already own the technology, and it might be at the patient access level or the call center level, and someone in a silo is doing something with the technology. And at that very hospital, I talked to a CMIO. Those are most of my friends and CIOs, and they're telling me about a problem that they're trying to solve manually, throwing bodies at the problem, cold calling patients, trying to get them to sign up for a portal. They have the technology in their own hospital. And now these are fun conversations for me, because I'm just like, well, I'm going to introduce you to the technology you already own, and you're going to tell me about that use case, and we're actually going to start solving it, right now, today.
It's interesting because automation is a conversation that came up a lot at the health conference, and I assume it's going to come up here at the CHIME conference as well. And part of that is just, we're looking at a significant nursing shortage.
we're actually going through vaccine mandates right now, and we're seeing a natural reduction in an already strained workforce. So that automation level, I assume, is the power of this. Is that pretty accurate?
Absolutely, that's one of many. It's loyalty and it's patient engagement and it's usability, but absolutely automation allows everyone on the healthcare side to operate at the top of their license. You want doctors doing doctor things and nurses doing not nursing things, and even front end staff doing things that are the most valuable that humans should be doing, not doing things that can be automated and taken off the table. And instead of the scale of someone following up on a patient and getting through 10 or 12 calls, you can do 100. 80%, empirically, 80% are taken care of through automation. 20% kick up. The higher level use cases are then dealt with by human beings who can do that higher order stuff. And then even more interesting, as you move along a month or two later, you can analyze what's bumping out to the humans and then add that into the automation and refine it more and more.
I think what my audience would want to hear is, how hard is this to stand up? So we have a lot of projects, we're bringing a lot of new stuff in.
Yep.
Is this a real heavy lift? It's not, I can hear the operational lift in the background, but from a technology perspective, it doesn't sound like that heavy of a lift.
Yeah, luckily it's not. It's already baked into the Cerner Healthy Intent platform to Meditech. It integrates really well with Epic and then a lot of other third-party vendors. And the beauty of it is, the genius of it is, it knows exactly where it should live in the ecosystem. Not trying to be the brains of anything. It's not the content curation or development in the background. It's very plug and play. You don't have to custom code everything. It just links into those. There's an integration, but once you're integrated into the major ecosystem partners,
then your operations team kicks in and they look at all the various touch points and say, could this be better? Anything other than text, I assume you can deliver pretty much on anything.
You can do IVR, you can do email, and a lot of places use it for links to enable telehealth visits through COVID and beyond. A lot of specialized COVID use cases that really popped up. Gave those out for free and got people using it, and that, of course, as we've talked about, a lot of the telehealth is now here to stay, and so those use cases have stuck, and other mission critical use cases out there.
So why continue to practice? Just out of curiosity.
Because for me?
Yeah.
My passion is kind of living on both sides of the fence. It keeps me honest both ways, right? The expression of eating your own dog food. I mean, you have to know what you're trying to do from the industry side. You have to know what the world of medicine is like, and healthcare is messy, but it's gratifying. So seeing patients now is still fun and gratifying in that way.
It's interesting because I had a CIO panel, all these CIOs who used to be doctors who became CIOs,
Sure.
and 3 of them essentially took a different approach to continuing to practice. One continued to practice because they're like, look, that's my credibility. Another essentially said, look, I can't in good conscience continue to practice because I can't keep up on all these skills that are required, and medicine is rapidly changing. And then the other one said, I went to telehealth visits on I think like two or 3 days a month, essentially. It's the least I could possibly do. And I'm seeing certain kind of patients, triaging stuff, so it's not like, it's stuff I guess you learn in your first year of med school kind of stuff. So so it always fascinates me why people either choose to continue to practice or whatnot. What do you think's top of mind? I asked you this question before. What do you think's top of mind here? The thing I'm saying, I think it's this labor thing. Is the thing I'm hearing over and over again is I just lost a handful of my staff from IT. I'm worried about my IT staff being that's now working remote getting plucked away from me, and obviously some of the nurse shortages and whatnot. They're getting tasked with that kind of stuff. That's what I think is the top of mind right now.
Yeah, we can chat about that for a second. I think burnout is a big issue and staffing issues, and it's been there for a long time. Got a lot worse during the pandemic, but from someone who works on the front lines, has done a lot of work that can be difficult work. It's less about the amount of work you're doing, but the type of work you're doing. And so if you're doing work that's what you actually want to do, and patient care, direct patient care, can be really hard work. But if it's directly impactful to the patient and you feel like you're using your skill set in an efficient manner and spending your time doing the things that you're trained to do, and it's having an outcome, even if it's a difficult outcome, someone's coming in, sick and dying from COVID, and you intubate them, prone them and send them to the ICU, that's difficult. But that's not where I get burnt out. Where the burnout comes from is if, despite all that stuff we're dealing with, and putting on PPE and donning and doffing that, and all the procedural changes and all that, if then I get blocked out of the EHR, or I can't message each other, and if there are all these artificial barriers and frustrating clerical or regulatory or compliance work or litigious stuff, that's frustrating, and that's not what you signed up for. And more in the U.S. healthcare system, the burden of that keeps increasing. And even some of the tools we use, like EHRs, are very good at passing the burden of documentation on to the front end user. Yeah. And nothing happens until it's documented to happen, and things like that turn into a lot of extra work and burnout.
It's interesting. This is going a little long, but I love when I get to speak with the doctor, because one of the things we tend to do in health IT, and I'm critical eye towards us, is we get excited about oh, I think this is going to solve interoperability. I've heard that like half dozen times since I came into healthcare. I think we've got it. One of the things I hear is ambient listening and voice and those kind of things. It helps, but have you worked a lot with various tools?
Have not worked with that, especially recently. We experimented with Google Glass a long time ago at our hospital. And I'll say this: I think it's really important to work from the use cases backwards.
Right.
Don't try to push sexy technology into healthcare because it's a great technology looking for a home. You really got to think about the use case first. Look at the atomic elements of that use case and figure out how they're best addressed. And sometimes it's technology that's already commercially available in a different industry. We're just not using it in healthcare for whatever reason, and fear of HIPAA violations, or for some other artificial reason. And maybe we should be using a proven technology in healthcare that's from other industries. Sometimes we have to start from scratch. But regardless, I'm a big fan of starting with what are we actually trying to do? And not replicating bad workflows or bad practice or voodoo that we've been doing for 20 years just because that's the way we've been doing it. But really think about what should we be doing here? And we should be getting doctors and nurses, to your point, focusing on the patient, caring for the patient, and allowing all that repetitive documentation and order entry and all these other things that are clerical somehow happen and be offloaded. And whether that's using AI or other processes and technologies, it's fine, but we got to be crystal clear about the use case first.
Right.
And just and that's the disruptive part. Start from that and kind of pull the technology into it.
Along the way. Sean, thank you for your time.
Yeah, absolutely.
Appreciate you stopping
Fun
by.
Talking with you as always.
There you have it. Hope you enjoyed it. We did 10 of these interviews at the CHIME Fall Forum. Hope you check back for some of those other interviews to catch what the industry insiders are saying about healthcare IT.